Hi there. My name is Dr. Matthew Leonardi. It's a great pleasure of mine to be presenting to you today. Thank you so much to the organizers for the kind invitation to speak about ultrasound as the first line and most appropriate diagnostic technique for bowel endometriosis. I am coming to you today from McMaster University, which is in Hamilton, Canada. I hope that you will enjoy this lecture. Here are my disclosures. And if anybody would like to reach out, they can connect through any of these social media platforms or email me. My email is listed just at the top there. I am a gynecologic surgeon and sonologist. I do advanced surgery for endometriosis, fibroids, etc. And I do advanced ultrasound for these complex gynecologic pathologies. I became a gynecologic surgeon and sonologist because of a main guiding principle that I had, which was I never wanted to be surprised when I got into somebody's abdomen with the findings of advanced pathology. I saw time and time again throughout my medical training, surgical surprises. And I thought, why is this happening? There was always a discrepancy between the radiologic reports and the surgical reports. And so I took it upon myself to travel to Sydney, Australia to do a fellowship and PhD under the supervision of Professor George Condis and become a sonologist to reduce the incidence of surgical surprises. Beyond my selfish desire to not want to be surprised at surgery, I also didn't want my patients to be surprised at surgery upon weight gain. To me, it seems very unfair for a patient to go into a surgery not really understanding what will happen, how long it will take, and truly what the risks of that surgery are. So I wanted to optimize the process of surgical consent by being able to give them as much information preoperatively as possible, so that way that information aligned with what I would tell them when they awoke from surgery. This is an article that I was invited to write as an editorial in the JMIG just last year, and wrote about how being a gynecologic surgeon sonologist is really very advantageous and hopefully will be more normal in the future. The outline for the presentation today is to list and discuss reasons why ultrasound should be the primary diagnostic technique and surgical planning tool for bowel endometriosis. Now, many of the reasons listed will apply to non-bowel endometriosis as well. So when we're going through this, just think about all endometriosis as a whole, but there are specifics to bowel endometriosis that we will highlight. Furthermore, we will demonstrate bowel endometriosis on ultrasound through pictures and videos for an opportunity for you to see what it looks like, normal and abnormal, and consider learning yourself. Prior to getting into the list of reasons, I do think it is always a good idea to review the various diagnostic modalities for endometriosis. Now, many of you will know that surgery, laparoscopic surgery, has been the gold standard diagnostic technique for endometriosis for many years, seeing the disease with one's eyes. Furthermore, obtaining a biopsy at that time of surgery allows for confirmation of the endometriosis pathologically. However, obtaining a biopsy is always dependent on surgery and therefore not a diagnostic technique usually all on its own. We have biomarkers, things like blood tests, urine tests, endometrial biopsies, various different specimens that may allow us to diagnose endometriosis or screen for endometriosis, but these are currently not in use and may hold future potential. The clinical diagnosis is that which a doctor says to a patient, you have endometriosis based on the symptoms and examination findings that they find. This is what I call the decent alternative to surgery. Clinical diagnosis may be useful if there is not access to surgery as a diagnostic technique or access to advanced imaging, which is our last pillar of diagnosis. And this is really, in my opinion, the non-invasive way to diagnose endometriosis. And this is what we should be relying on as our staple diagnostic technique in the future. The ESHRE guidelines have recently been published and do align with this approach as well. You'll see that one major change that they have made is that laparoscopy is no longer the diagnostic gold standard, and it is now only recommended in patients with negative imaging and or where empiric treatment was unsuccessful or inappropriate. Now, focusing on the first part of that sentence, The point is, if you see endometriosis on an imaging test, that is diagnostic. Therefore, one does not need to do a diagnostic laparoscopy to confirm the diagnosis. It is considered confirmed based on imaging. This is about diagnosing endometriosis, not treating endometriosis. There is, of course, still a place for treating endometriosis with surgery, even when that diagnosis is not achieved through surgery. Now, reason number one, ultrasound should be the primary diagnostic technique for bowel endometriosis. Ultrasound is non-invasive. It does not require any cuts to the body. It does not require any analgesia, other than occasionally some anti-inflammatory agents for pain. It is the most appropriate non-invasive way to diagnose bowel endometriosis, and in my opinion, it is the only acceptable solution to diagnosing endometriosis non-invasively for the bowel. Now, depicting this in a slightly different way, when we have a patient who has bowel endometriosis, many of them have gone undiagnosed historically, and not diagnosing bowel endometriosis is completely unacceptable. Patients must know whether they have endometriosis, and secondarily, whether they have or don't have bowel endometriosis. Diagnosing bowel endometriosis intraoperatively is also mostly unacceptable. It is not good enough. At the time of surgery, diagnosing bowel endometriosis does not allow a patient to learn of the diagnosis because they are under a general anesthetic. They cannot be consented appropriately for bowel surgery or not bowel surgery, depending on their preference. They also do not have an opportunity to meet the colorectal surgeon preoperatively. They do not have the opportunity to use bowel preparation or get appropriate antibiotic prophylaxis for the surgery if the treatment is going to be done at the same time. In many cases, when bowel endometriosis is diagnosed intraoperatively, the surgery is abandoned or is incomplete, potentially leading to a second surgery down the track. And this is not good enough. Finally, diagnosing bowel endometriosis preoperatively is the way to go. This is the only acceptable solution. Looking at this slightly differently, we have the historic approach of patients with bowel endometriosis undergoing a diagnostic laparoscopy, where that bowel endometriosis may be visualized. Then they are woken, told about the disease state, and booked for a second laparoscopy to treat that bowel endometriosis. With advanced imaging principles, advanced ultrasound, the first diagnostic laparoscopy can be abandoned in the vast majority of cases. Is imaging perfect? Absolutely not. But it is a way to diagnose this in a non-invasive fashion that allows for appropriate surgical planning for a single and very effective surgery. Diagnostic laparoscopy for treatment purposes should be a thing of the past. Reason number two, ultrasound is extremely accurate, and it is actually more accurate than surgery as a diagnostic test for bowel endometriosis. And this was recently demonstrated in a very lovely study published in Human Reproduction just in the last year. This study has demonstrated that diagnostic laparoscopy is actually very insensitive to visualizing bowel endometriosis. Bowel endometriosis, as depicted in this picture here, is often hidden under a mat of adhesions. In this picture, you can see our uterus is being anteverted by the suction device, and we have lots of adhesions in this space just here. The bowel is indeed stuck to the uterus, and so a surgeon can definitely say there are severe adhesions here. There is obliteration of the recto-uterine pouch. But can a surgeon with their eyes see bowel endometriosis here? Absolutely not. It requires a dissection of this plane to be able to start to understand whether there is bowel endometriosis there. And this, of course, is outside of the scope of many gynecologists who are not trained to dissect the bowel. So if we rely on surgery as a diagnostic test, this person may be told you have severe adhesions, but their bowel endometriosis would go undiagnosed. So ultrasound in that study published by Goncalves and colleagues was more accurate than surgery. There have been plenty of studies looking at diagnostic test accuracy for various imaging modalities with endometriosis, including specifically bowel, rectal endometriosis. This is a recent systematic review, again published in the last few years, demonstrating the diagnostic test accuracy of the various imaging modalities. Now I will focus on the two most common ones, which are ultrasound and MRI. And you can see here that ultrasound, transvaginal ultrasound, has a higher sensitivity and specificity than MRI. Now, this doesn't mean that one should not use an MRI. This means one should try to optimize the use of ultrasound as the primary diagnostic technique before MRI. MRI is definitely much more inaccessible and much more expensive, and definitely used beyond the gynecologic issues for so many other health concerns. And at least in Canada, there is a huge demand for MRI, leading to a significant backlog. The same idea does not exist with ultrasound, which is actually quite accessible readily. Ultrasound, as just stated, is cheaper than MRI, but it is also significantly cheaper than surgery as a diagnostic test. A non-invasive transvaginal and abdominal ultrasound is very, very inexpensive compared to a diagnostic laparoscopy, which carries huge cost and burden for the healthcare system, as well as the patient, who will inevitably need time off of work or school or their home responsibilities. And so it makes sense that we would use the cheaper alternative, especially considering we have just discussed that it is actually more accurate than surgery as a diagnostic test for bowel deep endometriosis. And we have actually demonstrated this in a study that I published as part of my PhD dissertation in the BJOG, looking at two pathways: a pathway of patients who undergo advanced deep endometriosis ultrasound followed by surgery, and a path where patients undergo diagnostic laparoscopy, and if bowel endometriosis or severe obliteration of the rectouterine pouch is identified, secondary surgery. And we have identified in this study, in an Australian population, for 1,000 women, that we would save the health system about 1 million Australian dollars. If you were to convert that to pounds, it would be about 500,000 pounds. So the pathway for the health system and for the patients, who may incur costs as well, is going to be cheaper by using the advanced imaging techniques rather than using surgery as a diagnostic test. Reason number 4 is that ultrasound gives you other valuable information. Focusing for a second outside of bowel endometriosis, ultrasound of the pelvis will allow you to diagnose uterine pathology such as adenomyosis, which should be factored into decision-making around treatments. As well, ovarian pathology can be diagnosed. Other areas of endometriosis can be seen as well, such as uterosacral ligament endometriosis, torus uterinus endometriosis, bladder endometriosis, parametrial endometriosis. We can evaluate the effect of endometriosis on the urinary tract system, particularly the ureters, which can be involved and compressed and leading to silent kidney death. So ultrasound gives you lots of valuable information outside of just looking for bowel endometriosis. But in the context of bowel endometriosis, we know from recent publications that ultrasound can help us predict the distance of the nodule in the rectum to the anal verge. And this has utility, in particular, in planning the colorectal surgery, as the amount of bowel that needs to come out and the height of the bowel relative to the anal verge that comes out may impair different risks in surgery, whereas lower bowel nodules have a higher chance, if there is a primary anastomosis, of developing things like anastomotic leak or fistula than lesions that are higher up. So this study has demonstrated that with ultrasound, we can predict the length of segment between the anal verge and the lower aspect of the bowel nodule very accurately. Moreover, the same group of colleagues has published a study demonstrating that we can accurately predict the extent of the infiltration of the bowel endometriosis in 3 orthogonal planes: the sagittal plane, the anterior-posterior plane, and the transverse plane. And this may have utility, again, in surgical planning, as the size and depth of infiltration of the nodule may allow us to decide which surgical approach is more appropriate, usually between a discectomy and a segmental bowel resection. So this study helps us in surgical planning as well. Reason number 5, ultrasound is accessible and it is easy to learn. There have been numerous studies looking at learning models, learning curve studies around bowel endometriosis specifically, in addition to other forms of endometriosis and adhesion states. And the overall sentiment is that this is not a particularly challenging thing to learn if you follow a very systematic approach and you have a mentor to teach you. In the absence of mentors to teach, There are alternative ways to learn, including learning from online resources. And for those of you that are surgeons, if you scan a patient, you can get immediate feedback from the surgery that you do around the state of the pelvis and the presence or absence of disease. So it is possible to learn. Now, let's learn a little. This is the IDEA study, the International Deep Endometriosis Analysis Group. This is a QR code that you can scan to actually get the article directly on your phone. And this is an article that I wrote with Professor George Condas, a very practical approach to diagnosing endometriosis on ultrasound. Again, you can use the QR code here. This is the overall outline of the approach, but for the purpose of today's presentation, we will be focusing exclusively on the bowel, the anterior rectum, rectosigmoid junction, and sigmoid colon. As per IDEA, we have 4 segments of bowel. We have the lower segment. This is the retroperitoneal segment. We have the upper rectal segment. This is intraperitoneal, the rectosigmoid, and the sigmoid. We should be measuring all lesions in 3 orthogonal planes. We also have various depictions of bowel endometriosis that are outlined in the IDEA statement. For the purpose of time, I'm not going to get into these, and thus far they have not demonstrated clinical utility per se. But there are a number of different appearances of bowel endometriosis that you can read about in that article. Now here is a video of a normal bowel. We have the muscularis layer here, which is hypoechoic, and we have the lumen of the bowel, which is hyperechoic. And between those two, we have a hyperechoic mucosa. In this next video, we're following that bowel segment as high up as we can. We're noticing very normal bowel muscularis. This is another video demonstrating up even higher as we get to the rectosigmoid and the sigmoid. In this still image, we have a bowel endometriosis nodule as depicted by a hypoechoic region here. You can see the normal muscularis caudally and cephalad. This is what it looks like at surgery. Again, reminding everyone that it is not possible to clearly see a bowel endometriosis nodule at the time of surgery. Here we have another video depicting bowel endometriosis with a retroflexed uterus and ovarian endometrioma and other posterior compartment disease. We freeze on that. This is what it looks like in a still image. Hypoechoic nodule compared to normal muscularis below and above. Here we have a video demonstrating a negative sliding sign with a bowel nodule right in this area here. Large hypoechoic nodule, very clear. When there are more than one bowel nodule, we need to measure the full distance of the bowel involvement and the space between them. Again, this is for surgical planning purposes to allow us to know whether we're going to be performing a much longer segmental bowel resection or potentially 2 separate procedures on the 2 areas of bowel involvement or more if there are more than 2. Again, IDEA recommends that we use the transvaginal probe to measure the distance from the caudal end of the nodule to the anal verge for surgical planning purposes. Because the bowel is sitting right behind the uterus and can often get stuck to the uterus, the sliding sign is very valuable as a dynamic test for evaluation of rectouterine pouch obliteration. This is how the IDEA consensus statement recommends performance of the sliding sign. But this is the reality. We have an anteverted uterus here, and we're ballotting the uterus through the abdominal wall with the hand holding the probe being very still. And we're visualizing the movement behind the uterus, the sliding of the uterus along the bowel. This is a positive sliding sign, a very normal state. In this next video, we're seeing that same technique utilized, but we're not seeing movement in that area along the posterior uterine serosa. It's stuck there. This is a negative sliding sign, obliterated rectouterine pouch. Again, we're seeing no sliding along the posterior uterine serosa between that uterine serosa and the bowel. And we actually do have a bowel nodule in this picture here, which is not the purpose of the video to depict that, but it is there at the same time as demonstrating the negative sliding sign. The ultrasound-based endometriosis staging system, first published by Menakaya and colleagues from Professor George Condas's unit, has been utilized to allow us to triage patients preoperatively based on the presence of either obliteration or bowel endometriosis, in which case they would be categorized as UBESS level 3. This is equivalent to the most complex gynecologic surgery that can be done. When we have this state, of endometriosis, we often want a multidisciplinary surgical team involving gynecology, urology, and colorectal surgery. We often utilize ureteral catheters when we have severe obliteration. We want to normalize the anatomy and excise all endometriosis, including the bowel endometriosis, which would require bowel surgery, often not performed by the gynecologist and will require the presence of the colorectal surgeon. So, in my opinion, ultrasound and non-invasive imaging in general is the gatekeeper to the optimal therapy, and ultrasound should be the primary diagnostic technique for the evaluation of bowel endometriosis, and it should be the technique used to optimize surgical planning when bowel endometriosis is present. I'd like to thank you for your time, but before I go, I would like to put a little plug in for a new ultrasound society, which is the Gynecologic Ultrasound Society of North America. This is a QR code that will take you directly to the Instagram page that is being used to educate people about gynecologic ultrasound with pictures and videos of all types of gynecologic pathology. I'd also like to plug the World Congress of Endometriosis 2023, which is going to be taking place in Edinburgh next May, the 3rd to the 6th. I will be there, and I hope to encourage some of you to attend as well. To meet in person, it will be an incredible event. Thank you again. It's been an honor to present to you today, and I look forward to the questions and answers.